Many wrist sprains begin with a load onto an outstretched, hyperextended hand. The severity of a wrist sprain can range from mild discomfort, lasting a few days, to major damage that requires surgical intervention. Sprains in general are classified into 3 grades of severity. Grade 1 is stretching and slight tearing of the ligament that leads to mild tenderness, swelling, and stiffness. Grade 2 is a larger but still incomplete tear of the ligament that leads to moderate pain, swelling, and bruising from bleeding. Grade 3 is a complete tear of the ligament that leads to severe swelling and bruising, and the patient may even report a feeling of instability during wrist movement. In addition to these grades, there is an alphabet soup of nomenclature used to classify wrist ligament injuries based on location. One commonly used term is carpal instability non-dissociative, which is a ligament disruption between the carpal rows and/or radius, but not within the row itself. A second term is carpal instability dissociative, a ligament rupture that occurs in the same carpal row. One of the more common sprains can occur with a dorsal triquetral avulsion. An avulsion is a bone fracture that occurs when a small fragment of bone attached to a tendon or ligament is pulled away from the main body of the bone. During normal wrist movement, there is a ligamentous restraint to motion linking the proximal row, but once ligaments are weakened or fail, predictable patterns of collapse occur. A partial or complete ligament disruption will tilt the lunate in the direction of the intact ligament. If the scapholunate ligament is ruptured or weakened, the scaphoid, since its energy is already moving towards flexion, will flex even further than normal because of the loss of the restraining ties to the lunate and triquetrum. The lunate, still attached to the triquetrum, will extend dorsally as the triquetrum extends even more than normal, since it too has lost its ligamentous restraints. This pattern is called a dorsal intercalated segmental instability, or dizzy, because the lunate rotates into dorsal extension. A rupture of the scapholunate ligament will, over time, create a gap between the scaphoid and lunate as the capitate descends with repeated muscle loading, driving the capitate into the gap between the scaphoid and the lunate. Failure to identify a scapholunate injury can progress into what is known as a slack wrist, a scapholunate advanced collapse, leading to the development of joint degeneration, starting at the scapho-radial articulation and collapse of the radial aspect of the wrist. In contrast, a rupture of the lunotriquetral ligament can result in a VISI deformity, a volar intercalated segmental instability, and now the lunate rotates into volar flexion. A dizzy can also be a part of a progressive ligament tear sequence, depending on the force involved during the injury. This sequence is known as a progressive perilunate instability, a devastating injury that is occasionally missed initially. This sequence of events has been classified into 4 stages. Stage 1, a scapholunate ligament rupture. Stage 2, an ulnocapitate dissociation through the weak area called the space of Poirier. Stage 3, a lunotriquetral ligament rupture. And the final stage, stage 4, in which the lunate may dislocate, often into the carpal tunnel.